These are case studies of cognitive disorders, psychosis, catatonia, and affective disorders to connect this with the realities that some psychiatrists see around the world. This is a case of delirium. The patient gets confused, disoriented, attentional abnormalities, but prominently with language abnormalities. He has a case of aphasia, and more specifically expressive or motor aphasia. The MRI shows many lesions. These are bacterial lesions. This is a case of a brain infection affecting specifically the frontal operculum, where the Broca area is, and other parts of the left hemisphere, contributing to the cognitive disturbances. By means of the inflammatory state, the patient goes into delirium. It happens often in general hospitals that once the patient is agitated, psychotic, or confused, they call the psychiatrist. Delirium can be explained by a brain disease. This is a different kind of problem. A case of a woman with psychosis, but severe cognitive disturbances like aphasia, mutism, drowsiness progressing to stupor. The EEG shows delta rhythms, but also a pattern of severe generalized dysfunction with a baseline activity in the theta range, as well as biphasic and triphasic sharp waves that occur periodically at certain epochs of the recording. And this leads to the diagnosis of Creutzfeldt-Jakob disease. This is a woman with a rapidly progressive dementia, and we can see severe hypometabolism in the molecular imaging, but the most specific signs appear in the MRI, in this case at the level of the striatum. We can see a hyperintense signal in the caudate and the putamen parts of the striatum. Now, this is moving into psychosis. This is another case of autoimmune psychosis. This is a case of an acute onset of Capgras syndrome. The patient was very scared of his own family members, thinking that they were imposters. In fact, the patient was calling for help to physicians to save him from the relatives. In this case, the MRI was normal and the essential cerebrospinal fluid analysis was normal. But before we had the specific antibodies in the cerebrospinal fluid, this is a case of anti-NMDA receptor encephalitis, molecular imaging showed that he had an asymmetric pattern with a severe hypermetabolism in the right frontal cortex. If you look at the pattern in different parts of the brain, you can see that besides the asymmetric pattern, there is an increased metabolism in the frontal lobe, but a reduction in the metabolism in the occipital cortex. Red flags to suspect autoimmune encephalitis, catatonia. This is one piece of research from our group, and this is a recent piece of research showing that these patients can have mania, depression, psychosis, but most of them eventually develop delirium and catatonia. This is another case of catatonia. The patient is in this abnormal posturing. This was an old man with a lot of strength to keep this abnormal posturing. This is one of the signs of catatonia, like immobility, mutism, stupor, staring, berbigeration, and others. But in this case, it was mainly immobility, posturing, and rigidity, but not like the features of Parkinson's disease. This is a different kind of rigidity that can lead to some specific signs like Gegenhalten or Mitgehen signs. And the image shows, in this case, severe hyperintensity in the medial temporal lobes, also in the insular cortex and the anterior and posterior cingulate cortex. So this is a case of limbic encephalitis, which improved significantly with treatment. This is a new piece of research from our group showing that cognitive disturbances are much more common in patients that have psychosis due to brain disease or neurological disease, not primary psychosis like schizophrenia or bipolar. But also, here on the right, we can see that in primary psychosis, in my own sample, this is 2,000 patients from my institute, primary psychosis, 3% of the cases leads to catatonia. But in psychosis due to autoimmune and other neurological diseases, catatonia can be present even in 90% of the cases. So this is significantly different. And we now would like to establish these features as red flags to suspect a specific brain disease that can be demonstrable at the level of brain imaging or at the level of EEG or lumbar puncture. It's important for us because it's a psychopathological red flag. So the psychiatrist needs to look for it, because other physicians, they're not trained to assess behavior and mental state.